The field hospital had been established in a converted school building on the outskirts of Osnabrück in the spring of 1945, one of dozens of temporary medical facilities that British forces set up as they advanced through Germany to treat both their own casualties and the growing number of prisoners and displaced civilians who required medical attention. The building's classrooms had been transformed into treatment wards, its gymnasium into a surgical theatre, its administrative offices into spaces for triage and record-keeping. The staff worked exhausting shifts dealing with an endless stream of wounded. British soldiers injured in the final fighting, German military prisoners suffering from combat wounds or disease, civilian casualties from bombing or artillery, refugees who had walked until their bodies failed. The work was grimly routine by this point in the war, a mechanical process of assessment, treatment, documentation, and either recovery or death, with little time for emotional engagement with individual patients beyond what medical professionalism required. It was in this context of routine medical chaos that Private James Mitchell, a medical orderly in his early 20s who had served with British Army medical units since North Africa, encountered a patient who would force him to confront the human dimensions of war in a way that years of treating casualties somehow hadn't. The patient was a German boy, perhaps 14 or 15 years old, wearing the remnants of a Wehrmacht uniform that was clearly too large for his thin frame. He had been brought in with other wounded German prisoners, and suffering from a shrapnel wound to his leg that was painful but not life-threatening. The kind of injury that required cleaning, suturing, bandaging, and monitoring for infection, but that would heal given proper care. The boy should have been a straightforward case, requiring perhaps 30 minutes of Mitchell's time before being transferred to the prisoner ward to recover. But from the moment the boy was placed on the examination table, something was clearly wrong beyond the physical wound that had brought him to the hospital. The boy was crying, not the sharp tears of acute pain that Mitchell had seen countless times from wounded soldiers, but rather a deeper, more sustained sobbing that suggested psychological distress beyond what the leg wound could explain. Mitchell's initial attempts to examine the injury were complicated by the boy's distress. He flinched at any touch, pulled away when Mitchell tried to cut away the torn uniform to expose the wound, seemed unable to focus on or respond to questions about how he had been injured or whether he had pain elsewhere. The boy's distress escalated as Mitchell persisted with the examination, his crying becoming louder and more desperate, his body rigid with what appeared to be terror rather than simply pain or fear of medical treatment. Other medical staff in the treatment area began to notice, and several paused in their own work to look at Mitchell struggling with this patient who was reacting as if the medical care being offered represented a threat rather than help. Mitchell stepped back from the examination table, recognizing that his standard approach wasn't working and that forcing the examination would only increase the boy's distress. Through the hospital's German interpreter, a refugee who had fled Nazi Germany before the war and who now served with British forces, Mitchell tried to communicate that he was there to help, that the wound needed treatment, that the boy was safe now despite being a prisoner. The interpreter's words seemed to have little effect. The boy continued crying, his eyes showing a kind of blank terror that suggested he wasn't fully present or capable of processing what was being said to him. Mitchell had seen shell shock in combat soldiers, had treated men whose psychological wounds were more severe than their physical injuries, but this seemed different. This was a child who had somehow ended up in uniform and who was now completely overwhelmed by circumstances he couldn't manage or escape. The situation reached a crisis point when Mitchell, needing to treat the wound regardless of the boy's psychological state, attempted to hold him still while a colleague prepared to clean and suture the injury. The boy's crying escalated into something close to screaming, and he began struggling against Mitchell's grip with surprising strength, trying to pull away from the examination table despite his injury. Mitchell found himself shouting, "Stand back!" to other medical staff who had moved closer to help restrain the patient, recognizing that adding more people to physically hold down a terrified child would only make the situation worse. The boy's distress had become so severe that Mitchell made a decision that violated standard medical procedures, but that seemed necessary given the circumstances. He released the boy, stepped away from the examination table, and told the interpreter to explain that no one would touch him or force treatment unless he agreed to it. The boy's response to being released was not immediate relief, but rather continued sobbing, though without the escalated terror that physical restraint had produced. Mitchell pulled up a stool and sat several feet from the examination table, not approaching or attempting treatment, but simply waiting, trying to project calm and non-threatening presence. The interpreter sat nearby, occasionally speaking quietly in German, explaining that Mitchell was a medic who wanted to help, that the wound needed care, that the boy was safe now despite being captured. Gradually, over perhaps 20 minutes that felt much longer, the boy's crying began to subside, though tears continued to stream down his face and his body remained tense and guarded. Mitchell used this time to observe details he had initially missed in the urgency of trying to begin treatment. The boy's extreme youth, barely into adolescence, his malnourished appearance suggesting weeks of inadequate food, the signs of exhaustion that went beyond simple physical tiredness, the way he kept looking toward the door as if expecting someone to enter and do something terrible. Through patient questioning via the interpreter, with Mitchell maintaining his distance and speaking in the calmest tone he could manage, fragments of the boy's story began to emerge. His name was Peter. Then he was from a small town in Bavaria, and he had been conscripted into the Volkssturm, the desperate last-ditch militia that Nazi authorities had assembled in the war's final months from boys and old men when trained soldiers were no longer available. Peter had received perhaps 2 weeks of minimal training before being sent to the front with a rifle he barely knew how to use and orders to defend against the British advance. He had been at the front for less than a week before being wounded and captured. A week during which he had seen things that his halting, fragmented descriptions suggested had been traumatic beyond his ability to process or articulate. Other boys he had been with had been killed, some by enemy fire, but at least one by their own officers when he tried to surrender. The Peter had witnessed violence that would have been difficult for trained adult soldiers to handle, experienced by a child who had been pulled from school and thrust into combat with no preparation for war's realities. Mitchell's anger at the situation was profound and complicated, directed less at the terrified boy before him than at the system that had put a child in uniform and sent him to be killed or traumatized. The medical training that had taught Mitchell to maintain professional detachment from patient circumstances failed completely when confronted with this particular case. He couldn't view Peter as simply another patient requiring treatment, but rather as evidence of something deeply wrong with how the war had been conducted, with decisions that had sacrificed children to prolong a conflict that was already lost. Mitchell had treated countless wounded German soldiers with professional competence, but without particular emotional engagement. They were enemies who required medical care according to Geneva Convention obligations, nothing more. But this boy crying on the examination table wasn't really a soldier in any meaningful sense, wasn't an enemy who had chosen to fight, was rather a victim of decisions made by adults in power who had been willing to throw children into combat rather than accept defeat. The practical problem remained that Peter's wound needed treatment regardless of the emotional circumstances, that leaving it untreated risked infection and complications that could threaten his life or leg. Mitchell explained this through the interpreter with as much gentleness as he could manage, emphasizing that the treatment would hurt, but that it was necessary, that Peter could hold someone's hand or grip something if that would help, that Mitchell would work as quickly as possible to minimize the pain and distress. Peter's response was not agreement exactly, but rather a kind of resigned acceptance, a nod that suggested he understood treatment was inevitable and would submit to it even though he remained terrified. Mitchell approached slowly, maintaining eye contact and speaking continuously in soothing tones even though he knew Peter couldn't understand his English, working on the principle that tone and manner could communicate reassurance even across language barriers. The treatment itself was technically straightforward but emotionally wrenching. Peter cried throughout the process, not screaming or struggling but weeping with a kind of hopeless misery that suggested he had reached a point of exhaustion where resistance was no longer possible. Mitchell worked as gently and quickly as he could, cleaning the wound, removing embedded debris, suturing the torn tissue, applying bandages, all the mechanical tasks he had performed hundreds of times on other patients, but which felt different when the patient was a traumatized child. The interpreter sat close to Peter throughout, holding his hand and speaking quietly in German, offering what comfort language and human contact could provide. When the treatment was finally complete, Peter continued crying, but with visible relief that the immediate ordeal was over, his body losing some of its rigid tension even as tears continued to flow. And the question of what would happen to Peter after treatment created complications that Mitchell hadn't initially considered. Standard procedure was to transfer treated prisoners to POW camps where they would await processing and eventual repatriation. But sending a traumatized 14-year-old to a camp full of adult German soldiers seemed both cruel and potentially dangerous. The boy needed psychological care and protection rather than simply detention with other prisoners. Mitchell spoke with the hospital's commanding officer, arguing that Peter should be treated as a displaced child rather than as a prisoner of war, that he needed to be transferred to facilities equipped to handle traumatized juveniles rather than to a standard POW camp. The commanding officer was sympathetic, but pointed out that military regulations provided limited flexibility, that Peter wore a German uniform and had been captured bearing arms, which technically made him a POW regardless of his age or conscripted status. The compromise that eventually emerged reflected British uncertainty about how to handle the increasing numbers of child soldiers captured in the war's final weeks. Peter would be held in the hospital rather than transferred to a POW camp, remaining there under medical supervision for psychological trauma rather than simply physical injury, until arrangements could be made to find him appropriate placement. And this solution bent regulations in ways that would have been impossible earlier in the war, but that reflected growing recognition among British authorities that the German military's use of children complicated simple application of POW procedures. Mitchell was assigned as Peter's primary caregiver during his hospital stay, partly because he had established rapport with the boy, and partly because the commanding officer recognized that Mitchell had personal investment in ensuring the child received appropriate care. Over the following days, Peter's physical wound healed normally, but his psychological condition remained fragile. He cried frequently, often for no reason that staff could identify, his tears seeming to come from some deep well of accumulated trauma that needed expression. He had nightmares that woke other patients in the ward, screaming in German about situations that the interpreter suggested involved combat or threats from officers. He flinched at loud noises, showed signs of severe anxiety when left alone, and demonstrated other behaviors consistent with what would later be recognized as post-traumatic stress disorder, though the specific diagnostic category didn't yet exist. Mitchell spent time with Peter beyond what his duties required, sitting with him during particularly distressed episodes, trying to provide the kind of stable, protective adult presence the boy clearly desperately needed. The other medical staff's reactions to Mitchell's involvement with Peter varied. Some colleagues supported his efforts, recognizing that the boy's situation was exceptional and that providing extra care was the humane response. Now, others suggested Mitchell was becoming too emotionally involved, that maintaining professional boundaries required treating all patients equally regardless of age or circumstances, that spending disproportionate time with one patient meant neglecting others. Mitchell found these criticisms frustrating because they seemed to miss the fundamental point. Peter wasn't just another patient, but rather evidence of something profoundly wrong that demanded more than routine medical care. The boy's tears weren't simply distress about his injury, but rather represented the psychological cost of decisions that had sent children to war, and ignoring that larger context in favor of strict professional detachment seemed to Mitchell like moral failure. Peter was eventually transferred to a facility for displaced juveniles, where he would receive care more appropriate to his age and needs than a military hospital could provide. Mitchell never learned what became of him after that transfer, whether he eventually returned to his family in Bavaria, whether he received adequate help processing his trauma, whether he grew into something approaching normal adult life, or remained damaged by his brief exposure to combat. The uncertainty troubled Mitchell, leaving him with unresolved feelings about a case that had affected him more deeply than years of treating adult casualties. The boy who wouldn't stop crying became, for Mitchell, a symbol of war's capacity to damage not just bodies but psyches, to traumatize those least equipped to handle violence, but to create wounds that medical treatment could only partially address. The incident also forced Mitchell to confront uncomfortable questions about his own emotional responses to different categories of patients. He had maintained professional detachment while treating countless wounded German soldiers, had felt no particular sympathy for adult enemies who suffered from injuries inflicted by their own side's military choices. Yet Peter's tears had broken through that detachment completely, had made Mitchell angry and protective in ways that adult prisoners never triggered. The difference was obviously Peter's age and conscripted status, but Mitchell wondered whether his response revealed something about how he had been dehumanizing adult German prisoners, that treating them as enemy combatants rather than as individuals with their own stories of trauma and coercion. The boy crying on the examination table had forced recognition that war's victims included people in enemy uniforms, that trauma didn't respect national boundaries, and that the categories of enemy and victim weren't always distinct.